So it starts to make me think about our cranial autonomic symptoms and specifically our trigeminal autonomic catharsias. So, what are the symptoms that we get along with these in addition to the head pain and the headache? So, conjunctival injection, the lacrimation, nasal congestion and or rhinorrhea, eyelid edema, forehead and facial sweating, and miosis or ptosis. And I think it's really important to say that these types of headaches and these types of syndromes, they are actually relatively uncommon. They're relatively rare overall as a cause of headaches and cause of presentations through to whether that's a general practitioner or to the emergency department. For these, people are usually very distressed and so more likely presenting to the ED, but still they're quite rare overall. So if we flick across to the next slide, this particular set of presentation and set of symptoms, this would be in keeping with a cluster headache. And a cluster headache is the most common form of a trigeminal autonomic catharsia. And these can include the cluster headaches. And I've popped in there the typical sort of duration of symptoms and how often it needs to be occurring to be make you thinking of these. So cluster headaches, paroxysmal hemicrania, the short-lasting unilateral neuralgia form headache attacks, and the hemicrania continua. And again, these are all actually quite rare in overall numbers, but they're really common questions that pop up for different exams along the way. So useful to learn sort of what the typical durations are. So if we go again across to the next slide, the answers in more detail. So subcutaneous sumatriptan is the answer in this case. And what we're really asking about is after we've commenced high flow, 100% oxygen for a cluster headache, what's the next line that we're using to try and help abort this event? So subcutaneous sumatriptan is the next line after the high flow oxygen. Oral caffeine is used in some types of headache syndrome. So post-LP headache, it's an adjunct in migraine treatment. Caffeine withdrawal sort of goes without saying, and hypnic headaches, which is a rare type of headache that can wake people overnight and surprisingly is caffeine responsive. Intranasal lignocaine would be the next option after subcutaneous sumatriptan, and it does have some evidence, but just nowhere near as much as the sumatriptan for sort of trying to abort the cluster headache. Intravenous fentanyl, sure, we use it when we're really grasping at straws, trying to get really severe pain under control. It's not one of the common things that we would reach for in headaches or migraines, etc., because it comes with a range of complications, including rebound headaches. And then finally, oral verapamil is a great medication for prevention of cluster headaches, not an abortive therapy, which is why it's not the right answer in this particular situation. So the next slide has then a really nice description of what the diagnostic criteria are for cluster headaches. I'm not going to go through this in detail. I'll let you guys have a little bit of a look, but Up to Date is a really nice article on that, both from the diagnostic criteria, and then the next slide after this is then treatment. And you can see the high flow oxygen therapy as the first line, sumatriptan as the second, and then we can consider other things as needed, but in the background, starting a preventative medication. All right, we'll crack on to the next question. So question 2. A 67-year-old woman presents to her general practitioner after an episode of right eye blindness. She describes the blindness as like a curtain coming down over the eye, which resolved spontaneously within minutes. She denies any other symptoms, including headache or pain over her temples. She has never had a similar episode before, and she's otherwise well with no fever, history of limb weakness, difficulty with speech or sensory change, a medical history of poorly controlled type 2 diabetes and hyperlipidemia. She takes metformin, gliclazide, and rosuvastatin. She has a 30-pack-year smoking history and drinks about 6 standard glasses of wine a week. Which one of the following is the most likely underlying condition? and keep moving. So the correct answer here is the carotid artery stenosis. And let's jump into that in more detail. So this particular question, the standout features, it's a 67-year-old woman. So it's an older woman. It's not a young lady. So first episode ever, sudden onset of right eye blindness, like a curtain coming down. And that's a really useful descriptive phrase. Resolves spontaneously within minutes, no other constitutional symptoms or headaches, and has a lot of vascular risk factors overall. So what we're talking about here, if we go to the next slide, is amaurosis. So amaurosis is a transient visual loss. When it's a single eye, so a monocular amaurosis, it implies a disorder anterior to the optic chiasm. So it either has to be the optic nerve or the eye itself. Binocular transient visual loss implies a posterior process involving optic chiasm and behind, so whether that's the trax, radiation, visual cortex. So in this particular case, again, if we go along to the next one, the timing matters and also the description matters. So a transient visual obscuration that lasts seconds only potentially could be something like raised intracranial pressure. People often describe this transient loss of vision. It might just be a little blotch, a little blur. And typically they're describing it when they're coughing, sneezing, bearing down on the toilet or getting off of a chair, anything that's got a Valsalva component to it. So they're raising their intracranial pressure even further, which is then causing that compression onto the optic nerve. A thromboembolic event, such as carotid artery stenosis, then causing something to flick off further, typically, if it resolves, is usually within minutes. So about 1 to 15 minutes is the typical description. And often people will describe it like a curtain coming down or a shade coming down, whether that's the entire eye or it's just a part of. So whether it's a branch retinal artery versus the main artery. Migraine aura, sure, definitely does cause visual loss. There's usually an evolving pattern over time. So it's usually more 10 to 30 minutes or potentially a bit longer. And it might start with those colored sparkly dots, the photopsias, before it then evolves into a field loss that could spread even further. So the answers in more detail. So migraine, why isn't it the right answer for this particular scenario? The visual symptoms are slower to present, and as we just described, they usually evolve from photopsias to field loss. It's not a sudden whole visual field loss. Carotid artery stenosis is the correct answer, and it's the most common cause of amaurosis, and it's atheroemboli coming from that internal carotid artery that's then going to either the ophthalmic or retinal artery or branch retinal. People often describe it like, as I said before, like a curtain coming down or like a horizontal field defect, which is quite different if you think to then the vertical field defects that you get in a, say, a homonymous hemianopia. Vertebrobasilar ischemia, sure, if there's significant sort of drop in the perfusion that's going through there, if it's affecting the brainstem, you're more likely to cause diplopia because that's where your oculomotor and other cranial nerves supplying your movement of your eyes are. And then if it's affecting unilateral occipital, it's going to cause a hemianopia. If it's causing bilateral occipital, you've got a really, really unwell patient. They're not going to be presenting with just a single eye change. They're going to be most likely unconscious, preceded by a bilateral visual impairment. Temporal arteritis is a really important one to have on the list here because it's the red flag one. It's the thing that we don't want to miss. And it definitely causes amaurosis, and definitely in this age group. So the data would suggest that we need to think about it over the age of 50, and it's exceptionally rare under that age. But it comes along with headaches, fevers, constitutional symptoms, and jaw claudication as being one of those other things that we always ask about. So do you start to get pain as you continue to eat a meal to the point that you have to stop because you're getting such significant pain? Does it settle down, and does that come back again as you start eating again? Not just do you get tired when you're eating. And then multiple sclerosis definitely can cause vision loss in a monocular pattern. It's usually a subacute onset though, and it's usually a subacute progressive over days. Can be painful or painless depending on where it is in that optic nerve. retrovulvar or vulvar, but it's also usually a younger population. So if we go back, this was a 67-year-old with multiple vascular risk factors. The most likely scenario for this particular person is going to be carotid artery stenosis causing then the amaurosis. All right, the next slide there. So again, up to date, had a really nice just table of causes of transient visual loss, and just popping it all there so people can have a look through in their own time. And then we'll go to the next question. Question 3. A 69-year-old man presents to the ED with a 2-hour history of sudden onset severe headache. The headache reached maximum intensity within seconds, involves his head and neck, and he described it as the worst headache of his life. He experienced a similar but less severe episode 3 weeks ago. He reports nausea, dizziness, and photophobia, a medical history of hypertension, chronic otitis media, and complete heart block, treated with a permanent pacemaker 30 years ago, and medications are amlodipine. He's a current smoker with a 40-pack year history and does not drink alcohol. On examination, he appears distressed, but is alert and orientated. His pulse is 88, blood pressure is elevated at 180/90, with a respiratory rate of 16, normal SATs and temperature, and a neurological examination otherwise reveals no focal motor deficits. So which one of the following is the most appropriate next investigation? I reckon we'll move forwards there. So the answer here is the non-contrast CT brain. So let's go through that. So 69-year-old, 2 hours of sudden onset severe headache, maximum intensity within seconds, worst headache of his life, with nausea, dizziness, photophobia, obviously distressed and hypertensive. So this is otherwise a subarachnoid hemorrhage until proven otherwise, but what he's actually presenting with is a thunderclap headache. So on the next slide, thunderclap headaches are severe, but the severity alone is not enough to call something a thunderclap headache. It's something that reaches maximal intensity within seconds. It's explosive and unexpected. And the two main things, subarachnoid hemorrhage is definitely number one. Reversible cerebrovasconstriction syndrome is something that we see and see more often than you probably realize if you don't work within a stroke unit. And there's lots of different causes for RCVS, including quite a range of polypharmacy, whether that's prescribed or things that people are taking themselves or getting off the street. There's actually quite a number of different causes for RCVS, but those are the two biggest things. There's a number of other causes for a thunderclap headache, including dissection, venous sinus thrombosis, a hemorrhage in a different compartment or within the parenchyma, as well as an infarct. But it's much, much less common for those to be the causes. And of everything there, the subarachnoid hemorrhage is the one that's most worrying right there and then. So if we go to the next slide, the answers overall, the formal cerebroangiography, so that's an invasive procedure. So if we're going in through a large artery to then proceed up to the intracranial vessels to visualize them better, in and of itself, it can cause stroke. So there is a percentage chance that it can cause a stroke. It's really good at detailed characterization of an aneurysm when you've already got something there that you can appreciate, or if you're trying to hunt for something like that. It's good for clot retrieval in strokes where there's a large vessel occlusion. And if you're trying to look at the really small vessels, it's a much better imaging technique, but it's not something that you have emergently available in front of you right there and then. A lumbar puncture is something that we do if the CT is negative and if we still have a high level of suspicion and if it's after 12 hours from the symptom onset. An MRI brain, it's not going to be the first imaging modality of choice in this situation when you've got someone acutely presenting. And it also, just as an additional part to the history, he's got an old model of a permanent pacemaker, so it's unlikely that that's going to be MR compatible, although a lot of the models these days certainly are. So the CT and the plain CT, that is the investigation of choice early in the symptom onset with sensitivity approaching 100%. The CT angiography can subsequently be performed looking for aneurysms, particularly if you have a subarachnoid hemorrhage. And then finally, the Dix-4 Pike is really an irrelevant thing in this situation. It's used to help diagnose things like BPPV, clearly not the situation that we're talking about here with a thunderclap headache.
Excellent. And I'd just like to, for anyone who's just joined us, remind you all that if at any point you'd like to ask a question, please do so through the Q&A function in Zoom. So we'll jump on to the next question.
Question 4. A 68-year-old woman is brought by her husband to see her general practitioner due to sudden weakness of her right arm and facial drooping. Several hours earlier, she suddenly experienced difficulty verbalizing, yet appears to understand what her husband is saying. The husband is concerned that his wife has had a stroke. She is left-handed. Upon testing her reception of speech, she can understand and follow instructions well. However, her speech is slow and dysarthric, with significantly impaired grammar and a reduced speech output. Neurological examination revealed pronounced weakness of the right arm with facial droop that spares the forehead with no other abnormalities found. Vital signs were otherwise unremarkable, has no history of ischemic heart disease or cerebrovascular disease, and does not take any medications. And a scan is ordered. Assuming that she has had a stroke based on the above findings, which of the following arteries is most likely to be involved? Okay, let's move forwards. So the answer here being the left middle cerebral artery, and there's something in this one that's probably going to have thrown people a little bit. So let's talk through. And 68-year-old lady, and the potential red herring of being left hand dominant. She's had sudden weakness of her right arm and a facial droop, and difficulty speaking, but could understand things. On exam, she had dysarthria, but also what sounds to be an expressive dysphasia with difficulties with grammar. So dysarthria is a problem with articulation. So it's a slurring of the words, but the words are all correct. There's no problems with the words that are being generated with the language that underlies it, but it's a problem with the articulation of those words. They're slurring. So she then also has the right arm weakness and a facial weakness that spares the forehead. So an upper motor neuron pattern as opposed to a lower motor neuron pattern, which would involve the forehead. So if we move forwards, We've just said that she's got a right-sided motor and an expressive dysphasia along with the dysarthria. So expressive dysphasia, it localizes to the dominant anterior frontal lobe. And dominance in someone who's right-handed is almost overwhelmingly always the left side. In someone who's left-handed, the dominance is more evenly split. So in some papers, it'll say it's 50% left, 50% right. And other papers even saying it's actually still a little bit higher in the left side, even if you're left-hand dominant. The motor weakness, however, if that's right-sided motor weakness and we've got an upper motor neuron facial palsy, it has to be somewhere along the motor tracks, either on the left side, so the left motor cortex, down through the subcortical regions, basal ganglia, brainstem, but it has to be above where that facial nerve nucleus is. So the only place that can localize these two things together is then a left-sided frontal infarct, because that expressive dysphasia has to be a cortical sign associated with the left frontal lobe. So the next slide, the answers here. So a vertebrobasilar, it's not going to give the expressive dysphasia. It's going to give us things that are posterior. It's certainly not going to give us that. A right ACA is going to predominantly give us left leg weakness, and depending on how big it is, it can give us a range of abulia and apathy, along with a couple of other things, but it's not going to give us that speech that we're describing here. Left ACA as above, but right leg weakness. A right MCA is going to give us left-sided weakness, which we don't have. So the correct answer here is the left MCA. It's giving us the right-sided weakness. So the right-sided facial droop and an upper motor neuron pattern, as well as then the arm. And again, the left side, regardless of what hand dominance you are, it's still much more likely to be the dominant lobe. In this particular scenario, we only have part of the language involved. We only have the expressive. We don't have receptive. So it's most likely that we're just going to have a branch of the MCA as opposed to the entire MCA. But in terms of localization, it's going to be the left MCA as the answer. Question 5. A 53-year-old woman presents to her GP with a 2-week history of pain in the right side of her face. She describes the pain as a dull ache with unexpected episodes of electric shocks, which she feels around her cheek and jaw. She finds that the pain is also triggered by brushing her teeth and chewing. She's tried regular Panadol and ibuprofen, but these have not provided any relief. She has no significant medical history and takes no regular medications. On examination, there is no visible rash and her dentition appears normal. Which one of the following is the most commonly recommended first-line management? Okay, let's move forwards. So the answer here is carbamazepine, and let's go through it. So 53-year-old, 2-week history of right-sided facial pain with the additional electric shocks and pain triggered by brushing her teeth and chewing. So she is describing a really classical trigeminal neuralgia. So on the next page, trigeminal neuralgia is characterized by recurrent brief episodes of unilateral electric shock-like pains. They're really abrupt in onset as well as termination. They usually last only a couple of seconds, but they can be horrendously frequent. So people can have more than 50 events of these a day. Some people are completely fine in between those abrupt onset of electric shocks, and some patients have a chronic low level of pain resulting from that or underlying that within that distribution. They occur in the distribution of one or more of the divisions of the trigeminal nerve, and typically it's more V2 and V3 after that, with less likely to involve V1, but it can be all of them. And then in terms of causes, we talk about compression of the nerve root as being one of the most common causes, and a vascular loop in particular coming in contact with the trigeminal nerve and causing these recurrent bouts. But it can also be idiopathic, as well as also potentially being a brainstem lesion. So a young patient who's had a sudden onset of trigeminal neuralgia would raise our suspicion of things like multiple sclerosis, as an example. Still nowhere near the most common answer for it, but it just raises our level of suspicion. Patients will really commonly talk about their triggers because they've realized there are things that just set it off. A common one will be having wind onto the face or air conditioning onto the face, just sets off this extreme electric shocks. Some people brushing the teeth or chewing, touching the face or talking. Sometimes we have to really push people and ask about these, but more often than not, people are actually telling you, I've realized that doing these particular things just really triggers it off. And you can see why on the next page, if we are then sort of looking at where this nerve is running. So on the left-hand side of the screen, you can see the trigeminal nerve coming forwards. It is sitting anterior to the ear, and you can then see the branches coming off from there. And so if those branches are firing off and sending pains, you can see exactly where it's going to, whether it's up into V1, it's to V2 or to V3. And then the picture on the right is talking about the most common cause being the vascular loop. So it's usually one of the cerebellar arteries that's looping through there and then impacting onto the trigeminal nerve to cause them these recurrent episodic shock-like sensations along the nerve. But I just thought that was some nice pictures that the Mayfield Clinic, which is a neurosurgical clinic, had put together as just a description. And so if we then go to the answers, so treatment for trigeminal neuralgia, we really need a neuropathic pain agent. And the first line medications are carbamazepine and oxcarbazepine. So answer one, ibuprofen, it's not usually effective. Answer two, carbamazepine, yes, it's a first-line neuropathic pain agent of choice for trigeminal neuralgia. If you start low at 100 milligrams twice a day and increase from there, aiming for maybe a max total daily dose of about 800 to 1200. But you can also use oxcarbazepine at 150 milligrams twice a day, and again, increasing up to a max total daily dose of 1800. Baclofen and phenytoin as the next two answers, they have some evidence that they are of use in trigeminal neuralgia, but they're not first line, so they're not as good as carbamazepine or oxcarbazepine, but certainly people try them as their agents after that, along with a range of other anti-epileptics like lamotrigine, for example. And then finally, paracetamol, really unlikely to be helpful given that this is neuropathic pain overall. Okay, question 6. A 27-year-old man presents to the GP with a three-day history of nausea, vomiting, and sensation of the room spinning. His symptoms are worsened by position or movement, and he notes instability when walking. He denies headache, eye pain, or hearing loss. There has been no recent weight change, fever or night sweats, or excessive fatigue. The patient recalls having flu-like symptoms approximately 1 week ago, which resolved without treatment. No significant medical history and takes no regular medications. On examination, he appears unwell. Vital signs are within normal limits. His cardiorespiratory exam is unremarkable. Neurological examination reveals no abnormalities, including of sensation, muscle strength, hearing, or speech. However, he veers to the left on walking. On cranial nerve exam, unidirectional nystagmus, that is worse on left lateral gaze, is noted. but there are no other abnormalities. The head impulse test reveals a corrective saccade when his head is turned to the left. There are no abnormalities on testing skew. Which one of the following is the most likely diagnosis? Great, let's move forwards. So the answer here being vestibular neuritis. And I'm not surprised that this one has got a range of different answers across it because it is something that throws people quite a lot. So let's go through the discussion. So again, 27-year-old, 3-day history, nausea, vomiting, and vertigo, worsened with movement. No headache, eye pain, or hearing loss. The constitutional symptoms recently, and then unidirectional nystagmus, worse on left gaze, the head impulse with a corrective saccade, and no skew. So next page, what we're talking about here is then acute vertigo. And time course is critical for pathology with this. So an acute episodic vertigo lasting less than a minute, we're usually dealing with BPPV. An acute single episode lasting minutes to hours, it could be a first presentation of vestibular migraine. It could also be ischemia. And in that setting, you'd be asking about acute sensorineural hearing loss as well and checking for that. An acute episodic lasting minutes to hours could make us start thinking about vestibular migraines or Meniere's disease, and that's usually associated with hearing loss, tinnitus, oral fullness. And prolonged severe episodes lasting days would start to make us think about things like vestibular neuritis or lesional problems. And we'll go through this in a little bit more detail now. One of the big things here that this case is partially built upon is the HINTS examination. I think it's really important to talk about this for a second because this gets thrown around a lot and gets used a lot in clinics. But this is a test that's been validated when there's an acute constant vertigo. So once that's already resolved, there's not really as much use in this test and it's not validated in the same way. But the HINTS examination, a 3-step bedside ocular motor test used to differentiate central from peripheral causes of acute constant vertigo. And again, as long as there's no focal neurological changes otherwise. So the head impulse, we're doing a rapid passive rotation with the eyes fixed on a target. So we're asking someone to fixate forwards and we're doing a quick movement of their head from one side to see if there's a corrective saccade. We're doing it to both sides to see how do people go with maintaining that constant fixation. So normally people should have the ability to fixate. In a peripheral cause of an acute constant vertigo, there will be a corrective saccade so that it will catch up. It won't be able to maintain fixation. And that's a positive finding in the HINTS pointing towards a peripheral lesion. If you have someone with acute constant vertigo that's ongoing and you're doing a head impulse and there's no saccade, that's when you think about a CNS cause. Nystagmus is then the second part of HINTS. And what we're looking for is unidirectional nystagmus because that's peripheral. And we often talk about it being horizontal, but it's actually quite commonly a combination of horizontal and torsional. So we're looking to see, is the eye beating fast to one side? And does that sort of rate and speed continue in all directions of gaze? It might get a little bit better when you're looking to this side, but you're still maintaining that same beating. Bidirectional is when you look to the right, it goes to the right. When you look to the left, it goes to the left. So it changes the fast phase of the nystagmus. And that's similar to gaze evoked. So bidirectional gaze evoked, when you look up, you then also get up. But also, if you have isolated vertical nystagmus as your nystagmus, that's always CNS until proven otherwise. So that always makes me worried if someone has a vertical nystagmus and no horizontal. That would always be CNS until proven otherwise. And then finally, test of skew is really just looking to see, are the eyes conjugate or not? So both eyes should be looking forward and coming together onto a single target. To check that, you're asking someone to look directly at your nose and you're covering one eye at a time to see, is there any sort of corrective saccade of the eye that's not covered to suggest that that eye isn't lining up with where it should be going, where it was with the other eye. So we're doing one eye at a time. So there shouldn't be any sort of skew in a peripheral source. But if there's a corrective skew or corrective eye drift, again, that would be a sign pointing towards CNS, or at least needing to have CNS excluded. So Hintz examination, really useful when there's acute constant vertigo, trying to safely differentiate between peripheral and central. So then if we move forwards, I've just popped one particular video talking about the Hintz examination. There's lots and lots and lots of different videos that you can look up, and lots of different videos of people with pathology and how the eyes look and what they do across different ones. So this is just one particular one, but you can have a look and see a range of different ones. So next slide again. The answers here. So BPPV, brief episodes of vertigo, usually triggered by specific head movements. Labyrinthitis follows a viral infection similar to what we've had in this case. It involves the vestibular nerve, but also the cochlear nerve. So hearing loss is involved, which in this particular case, it's not. Meniere's disease, episodic vertigo lasting hours with fluctuating hearing loss, tinnitus, and oral fullness, for which we don't have any of those things. And we've also had a persistent syndrome now over a few days. And sorry, I forgot to say with BPV, we've had a persistent syndrome over a few days. It's not we're having brief episodes that are settling down and then coming back and settling down and coming back. We've had a constant, which is why one of the reasons why it's not BPV. So answer 4, vestibular neuritis follows a viral illness just like this, acute vertigo lasting days to weeks with preserved hearing. We find that a Hintz examination pointing towards a peripheral source. And then finally, posterior circulation stroke. The Hintz examination would be different to what we've had in this case. It would be something pointing towards a central source. Okay. Question 7. A 67-year-old man presents to his neurologist with a 12-year history of idiopathic Parkinson's disease and 6 months of worsening motor fluctuations. Although symptoms are often manageable, he struggles to partake in his usual hobbies and to independently achieve some activities of daily living in the hour or so before his next dose. His mood remains fairly stable. His current regime is oral levodopa-carbidopa 300/75 3 times daily and pramipexole 1 milligram 3 times daily, which was added previously to treat similar motor fluctuations. On exam, vital signs are with normal limits, and he has a mini mental of 28 out of 30. Which one of the following is the most appropriate next step in management? All right, let's move forwards. So the answer here is increasing the dose fractionation. So 67-year-old male, 12-year history of Parkinson's disease with 6 months of worsening fluctuations impacting his independence and quality of life in the 60 minutes prior to the next dose. Mood stable. He's got a big dose already of levodopa carbidopa. He's got a big dose of pramipexole at 1 milligrams TDS. And for those people who were part or listened to the first webinar, you remember we had a similar question where it was asking about what do we add in for someone who is already on levodopa carbidopa, and then what are the complications or side effects. So pramipexole, dopamine agonist, and one of the big things we have to worry about are those impulse control disorders like we talked about last time. So in this particular case, we're talking about someone who's got a well-known diagnosis, who's actually pretty well, but it's just that we've got a wearing off effect before the next dose. So if we go to the next slide, Parkinson's disease itself, we have a chronic progressive degenerative loss of dopaminergic neurons in the brain. And I think it's really useful to say, if we think about this case of 12 years in duration, it's not just that the dopamine production is decreasing over time, it's also that the brain can't store the dopamine for as long. So if we're taking increasing doses of dopamine, it can't store it for as long. So we, over time, need to increase how frequent that dopamine replacement is occurring. The cardinal features of Parkinson's or idiopathic Parkinson's disease are rest tremor, usually asymmetric and usually spreads over time, presenting symptom in about 70% of people. Bradykinesia, so the slowness of movement and decreased amplitude of movement, which is a really disabling symptom for a lot of people. The rigidity, which is classically a cogwheel rigidity, and postural instability, so decreased ability to prevent falling. This is usually a late manifestation of Parkinson's disease. And again, we talked about a different case of an atypical Parkinsonism in the last webinar, where falls were an early feature, which makes us start to think about atypical causes for Parkinsonism. Finally, there should also be a clear response to dopaminergic therapy for idiopathic Parkinson's disease. So if we go to the next slide, we've just talked about the motor manifestations, but just as important is the non-motor manifestations. And increasingly, it's being recognized that these non-motor symptoms are more concerning for patients, more disabling and less responsive to medication therapy. So often our pharmacotherapy, where we're targeting tremor, rigidity, bradykinesia, is really having not much of an effect on these other things like cognitive dysfunction, potentially psychotic symptoms, mood disorders, depression, anxiety, or apathy and abulia, which is quite a common one. Sleep disturbances, fatigue, autonomic dysfunction is quite a common one, and that marries into the gastrointestinal dysfunction, as well as pain and sensory disturbances, which people struggle to describe, and there's no peripheral cause for these, but it's actually related to their Parkinson's disease. The next slide. The answers here, going through it in a little bit more detail. So the first answer was just increasing the levodopa carbidopa dose, just full stop. He's already taken quite a big dose, and it's giving a wearing off effect 60 minutes prior to his next dose. So just giving a bigger dose but continuing the 3 times a day is not really going to do a very good job of addressing that wearing off effect, because it's that difficulty with the brain with storing the dopamine. And potentially, if we bump the dose up higher but keep it as TDS, we're more likely to start running into medication complications like dyskinesias. So increasing the dose fraction is the correct approach. So splitting it rather than 3 times a day out over, say, 5 times a day. You could be forgiven with going 4 to 5 to 6, but increasing how frequently you're giving the medication to try and make that dose a little bit more consistent, even though we know it's doing this. Switching the dopamine agonist, he's already on a big dose at 1 milligram TDS, and I think it's unlikely that that's really going to give much or significant improvement by changing him to something else, but it's quite likely to cause quite significant dyskinesias when you're changing big doses of dopamine agonists around. A dopa pump is a good option when further fractionation isn't possible. So when oral dosing is exhausted and you're having either significant on or off side effects, this can be a really good way. But again, you'd want to maximize your oral therapy first. And similarly, the deep brain stimulation, it's a good option when there's significant on and off side effects, when there's still a strong dopamine response to the patient, but significant side effects. Those 2 options could be a really, really long talk in and of themselves, and I'm going to leave that for now and for here. But for this particular patient with TDS dosing, we would break the dose up a little bit further to give them a better benefit over that longer period of time. Okay, question 8. A 35-year-old woman presents to the ED with a 3-day history of left-sided weakness and numbness. She reports that her symptoms began after she was involved in a motor vehicle accident as a restrained passenger. She sustained no physical injuries but witnessed her sister being seriously injured. She's been unable to work since the accident and is seeking a medical certificate for an insurance claim. She has a medical history of depression and adverse childhood experiences. Her regular medication is sertraline. On examination, she appears distressed and tearful when discussing her symptoms. Her pulse rate is 88, blood pressure is normal, rest rate, SATs, and temperature all normal. Her neurological examination reveals weakness of the left arm and leg that gives way suddenly during testing. Sensory testing shows decreased sensation to light touch on the left side that stops exactly at the midline. Deep tendon reflexes are symmetrical and plantar responses are flexor bilaterally. When asked to raise both arms, the left arm drops immediately, but when distracted by questions about her sister, the left hand is observed adjusting her hair. She becomes frustrated when unable to perform tasks and repeatedly asks about her prognosis and ability to return to work. Her imaging and blood tests are all unremarkable. Which one of the following is the most likely diagnosis? Yeah, great. Let's move forwards. So the correct answer here is a functional neurological disorder. And again, I was wondering how many people were going to pick between that and malingering, but let's go through it in quite some detail. The 35-year-old woman, the 3-day history, onset after an MVA where she saw her sister being injured, unable to work and seeking a medical certificate with a history of depression and adverse childhood experiences. And on exam, she's distressed and tearful with a neuro exam with give-way weakness, sensory loss that stops at the midline, and variable distractible weakness. So we're talking about a functional neurological disorder here. So the give-way weakness, the distractibility, the non-anatomic sensory loss, and the relevant yellow flags, but also that she's quite distressed with what's going on. And there's this element of variability and distractibility. Malingering is actually quite uncommon, so it's really, really rare. The vast majority of presentations are of functional neurological disorder, and it's really quite rare for there to be malingering. But malingering is a deliberate fabrication or exaggeration of symptoms for external gain. This patient seems genuinely distressed by her lack of function, and there is the variability, implying it's a subconscious driver as opposed to a conscious driver. Multiple sclerosis doesn't fit for a range of reasons, similarly the stroke and the migraine. So let's talk about this in a little bit more detail. So functional neurological disorders are incredibly common. So they're the second most common presentation to a neurology clinic when looking at all of the presentations that come through both clinic and hospital. It's common, disabling, and historically misunderstood group of conditions, and characterized by neurological symptoms not explained by structural or degenerative pathology, increasingly recognized as having identifiable neurobiological, psychological, and behavioral underpinnings. And once relegated to a diagnosis of exclusion, the field has advanced quite significantly, and now a while ago, with the identification of the positive clinical signs that support the diagnosis. So it's not a diagnosis of exclusion, and it's not helpful to talk about it in that way. It's a diagnosis made by positive clinical findings that we see on examination in conjunction with also reassuring other tests. The next slide. So there's quite a broad variety of functional neurological disorders, and I've included a little bit of a description of functional limb weakness and functional tremor here, which we'll go through in a second. But underneath that, we've got functional jerks, functional movement disorders, functional Parkinsonism, gait disorder, visual loss, cognitive, non-epileptic seizures. The list goes on. There's quite a long list of functional neurological disorders. And the article that I've popped the link there to goes through that in quite some detail. But functional limb weakness, it's inconsistencies with neuroanatomical principles. So weakness that spans the entire breadth of the arm, as an example, but no other deficits that would make sense with how that pathway is working. Preserved capacity for function despite the reported disability. So despite being unable to move the arm, still being able to care for yourself or to use that arm to do something. We talk about Hoover's sign, which is a really nice way of looking at lower limb weakness and variability and how the leg is working when it's being asked to do something versus not. And there's lots of videos that you can look at with Hoover's sign. And there's a couple of different ways you can do this as well. We talk often about collapsing or give way weakness when you're testing the weakness out here and it just suddenly drops. It's not how normal testing occurs. If there's weakness there, it's sort of overcomable and you can push it down. It doesn't look like something just drops or gives way. There's variability in the effort and the power. It can be 5 out of 5 at 1 minute and 3 out of 5 and then back to 5. And if you repeatedly test it, you can see that variability. We talk about entrainment, and entrainment is both with limb weakness as well as other features. But one of the ways you can look at entrainment with power testing is if you're testing the affected arm and then you're getting them to do something with the other arm, and you start to get them to go to a certain rhythm or do a movement to a certain rhythm with the other side, you can see it starting to occur with both sides. So that's what entrainment is. Similar to tremor with entrainment, if you've got someone who's got this weird fluctuating tremor over here and you get them to start just gently moving their wrist up and down, it sort of starts to get into the same rhythm as the other side. Functional tremor, we talk about inconsistency of the tremor itself, the inconsistency of the frequency and the amplitude, and that's also then the variability component, the entrainment, which I just briefly demonstrated, tremor inhibition, and using other distractibility techniques like counting backwards or engaging in conversation causes the tremor to fade away. So there's lots and lots of positive clinical signs, and it's quite useful to learn about some of these positive clinical signs and to use them because it's such a common presentation. And again, using that terminology of we've ruled everything else out is not a good way of talking to or thinking about functional neurological disorders. It's a positive diagnosis made off positive clinical findings as well as excluding other things. And it should be spoken about in a positive way as well, because once a diagnosis is given, there actually is quite good recovery for most people, particularly if we can give that diagnosis early and start moving forwards with recovery. So next page, I've included a couple of websites here that I find really, really useful. So neurosymptoms.org, we use that at least once a week. So printing out patient handouts for functional symptoms with really beautiful descriptions of what it is and it's for patients. And FND Hope as well, a really nice website talking about the recovery and how things can get back to normal when you've been diagnosed with a functional neurological disorder. You'll find a lot of people will unfortunately dive deep into a range of different online forums, and the commentary online is really not that helpful for people's recovery and really quite nasty in some centres. So using websites that actually have that description, that education there is a really nice way of helping to reassure people, to teach them and educate them about their symptoms as well as the potential recovery. Question 9. A 24-year-old woman is an inpatient being treated for infectious colitis acquired during an overseas trip. She has a history of epilepsy and usually takes sodium valproate, but has been vomiting for 3 days and unable to keep down her medications. A code blue is called as she begins having generalized tonic-clonic seizures. 2 doses of intramuscular midaz 5 milligram have been given 5 minutes apart, each assessed for response with no effect. She has now been seizing continuously for 14 minutes. Pulse rate's 120, blood pressure's 160, respiratory rate 24, SATs are 92 on room air, and temperature of 37. She's unresponsive during ongoing generalized tonic-clonic movements in all 4 limbs. Which one of the following is the most appropriate next step in management? And we'll keep moving with this one, just being mindful of the time and that we ran a bit over with the last one. So the answer here is commencing intravenous levetiracetam. So the case here, 24-year-old, known epilepsy on valproate, unable to keep oral medications down and seizing constantly for 14 minutes with 2 doses of Medaz already. So next slide, this patient has status epilepticus. So generalized convulsive activity of 5 or greater minutes, or where there is recurrent seizures without return to normal state between. We previously used a longer duration to call something status epilepticus, 30 minutes and then 20, and now it's 5. And the rationale is really the longer the duration, the less likely it is to spontaneously settle, and the increasing likelihood for serious injury, neuronal damage and death without recovery, so significant complications that can occur. Focal motor status doesn't really have a technical duration of where we would call it. Some people would use 30 minutes, and I guess that's a reasonable one to use. And then non-convulsive status epilepticus, 10 minutes or greater, although it's less clear the duration here to cause damage. But this particular patient is in status epilepticus. So then how do we manage it? So if we go to the next slide, the treatment here, short-acting benzo is the first line, and that's any of IV, IM, or intranasal of diaz, midazolam, or lorazepam, depending on what you have available. We talked last time about a range of different options, and in that particular setting, giving something intramuscular because you don't have access any other way is completely fine and a good first therapy. We've already given 2 doses here, and there hasn't been effect. So then the second line agent for status, all of these are equivalent. So phenytoin, valproate, or levetiracetam loading at the doses before. And I think it's just a really nice way of remembering them as 20, 40, 60 as the doses that were used for loading. They each have potential pros and cons, but I've attached the paper below that was in the Lancet, which is really what has then changed our seizure management over the last couple of years. And I think you'll find that a lot of emergency departments and medical wards and ICUs, along with neurology units, have gone with using much bigger doses than we ever used to use before. So you can see there the valproate up to 3 grams or levetiracetam up to 4.5 grams. Importantly, this is for status. This isn't just a routine run-of-the-mill seizure that's come through and already settled down, but this is for status epilepticus. So if we go to the next slide, the answers in this particular case, number 1, inserting a nasogastric for medications. No, it's going to be too slow to get it in, too dangerous for the ongoing seizures. And with the secretions, etc., it's just not going to be over a safe administration, a slow administration compared to IV. So of what we have here, we only have one option of those 3, so intravenous levetiracetam. The oral valproate, it's going to be unsafe during the seizure with the secretions impacting absorption, and it's just going to be too slow. Observing for another 10 minutes, no, she's already been seizing for 14 minutes, so she's already been in status for 9. She's failed 2 doses, and she's just going to increase her risk for having more complications and more after effects if we allow this seizure to continue. And the final answer, a 3rd dose of Medaz, it's reasonable to say she's already failed 2 doses, and we need to be giving her something more at this point in time. So adding in a different agent to try and target this in a different way. So any of the levetiracetam, valproate, or phenytoin. But a lot of people would also potentially give an additional dose of Medaz in conjunction with those things or after those things if seizures were continuing, because benzos are still going to be a really useful adjunct. But it's now, we've done 2 doses, it hasn't worked yet. We need to add something else in before we then keep going down that path. All right, and our final question. A 6-year-old boy presents to the emergency department with a 3-day history of progressive leg weakness and difficulty walking. 2 weeks ago, he had a gastrointestinal illness with diarrhea that resolved spontaneously. He has no significant medical history and takes no regular medications. His immunizations are up to date. On examination, he appears well. His pulse rate is 88, blood pressure 105 on 65, respiratory rate of 20, SATs of 98 on room air, and temperature of 36.8. He has symmetric weakness of both legs, at 3 out of 5 power with absent deep tendon reflexes. Upper limb power is 4 out of 5 with reduced reflexes. Sensation is intact, and cranial nerve examination is normal. His CSF was tested and he has a protein level of 0.8 with a normal cell count. Which one of the following is the most appropriate next step in management? No forwards. So the correct answer here is the intravenous immunoglobulin. So a 6-year-old, 3-day history of progressive leg weakness and difficulty walking, 2 weeks prior a GI illness, and we've got weakness with absent reflexes and albino-cytologic dissociation on testing. So on the next page, this patient has Guillain-Barré syndrome. So an acute inflammatory demyelinating polyradicular neuropathy. So it's an immune-mediated problem. It's usually presenting with an acute progressive symmetric weakness with often sensory alteration, but motor is more than sensory usually. Often there's a prior infection or vaccination or other trauma, but not always. They may have autonomic dysfunction and respiratory and cranial nerve involvement, which thankfully we don't have in this case. But some of these patients can be critically unwell and need to be in ICU and intubated with quite profound autonomic problems with malignant tachy and bradyarrhythmias as potential side effects. The symptoms usually reach a peak within about 2 weeks, but definitely by 4 weeks, and then plateau and start recovering at a variable rate. And there's a range of different things that can be used to look at potential prognosis. But if something is continuing to progress after that 4-week mark, or we're having fluctuations and getting worse, that's when we start to think about things like CIDP, so chronic inflammatory demyelinating polyradicular neuropathy, rather than Guillain-Barré syndrome. So on the next page, the answers. The IV methylprednisolone, it doesn't help GBS, and in fact, it can actually worsen your recovery. And we contrast that with CIDP, so the chronic version, where actually steroids are a mainstay of treatment. So whilst we simplistically call one an acute version and one a chronic version, there's a difference in the pathophysiology underlying, which is why corticosteroids work in CIDP but don't in GBS. So intravenous immunoglobulin, yes, it is the treatment of choice, and it has an equivalent outcome to plasma exchange for treatment of GBS, but it's typically cheaper, more readily available. It's easier to commence. There's no need for central lines, and there's less issues with significant fluid shift complications. Oral prednisolone, again, as above. Plasmapheresis, it is as efficacious to IVIG. So the outcomes between GBS sufferers having either of IVIG or PLEX is the same, but it is more complicated typically, and it's reserved where IVIG is not available. It's contraindicated, so potentially they've got thromboses there, which IVIG we wouldn't want to give someone further protein loading and increasing their clotting risk further if they've got uncontrolled clots. And anecdotally, we often use it or reserve it for rapidly severe cases. So if there's really significant compromise within only a short space of time, I think most clinicians would probably end up deferring to plasma exchange, because there's the thought that it's going to be getting into the system quicker and having effect earlier. But realistically, IVIG is going to be the first line for most places. And then finally, supportive care. It's not appropriate when there's significant weakness already there and the functional impact. So it is appropriate if you've got someone with very mild symptoms that's not causing any functional decline, particularly if you're already, say, 10 days into their overall symptoms, they've already reached their peak and they're starting to get better. Supportive care is quite reasonable. Okay. And that should be the end of it there. So thank you very much for everyone for sitting through that, for taking part.
No, and thank you, Andrew, for your Absolute phenomenal explanations of those questions, and I can definitely vouch for myself, at least that I've learnt a lot from going through those cases this evening. So, thank you everyone for attending. We'd like to just take a small moment to kindly ask you to fill out an evaluation of this evening's webinar, which I have just posted a link to in the chat of the Zoom. Also in the webinar chat, you'll find a link on how to generate your CPD certificate, and as well as a link to all of our past webinars, where there's a series of recordings, and there's also some upcoming dates of our SWAT September, where we'll be hosting weekly webinars on Wednesday evenings, covering a whole range of topics ready for your medical school or AMC examinations. A recording of this webinar will be made available on the website shortly. You can also save tonight's collection using one of the links to your own eMedici user account for revision. And so we ask you to please kindly fill out the evaluation. One person will be chosen at random to win a 3-month subscription to either our clinical medicine or junior doctor pack, as an appreciation for your feedback. So, thank you all for joining us, and thank you again to Andrew and Nathan for helping out in the background. We wish you all a wonderful evening and have fun studying.
Thanks, guys.